Okay. Good morning, everybody. Josh Burton here again with Dr. Harrington. We're going to start off the altered mental status portion of the COMAT Review Series. Kick things off first with seizure. All right, let's go. Again, this is going to be very the biz bugs, high-yield topics to make sure that you guys get the most questions right on the exam. So generally when you get a question that starts off with a patient who is seizing, first things first, medical history, you're looking for medicines, you're doing a neurologic exam. And then as far as tests go, the number one important thing is checking a glucose. So person is seizing, what's the first step to do, or what's the first test to order? Point of care glucose is what you're looking for. And if it's a female of childbearing age, you're looking for that pregnancy test to go down a pathway of like preeclampsia or eclampsia to cover those. If this is an adult and it's a first-time seizure, the question always is, is this a seizure or is this syncope? Commonly confused when you're getting like a report from EMS, that sort of thing. So in the question stem, if it reads, unserved seizure-like activity, EKG is typically ordered to look for, things of syncope, which we'll go over in the syncope lecture here in a little bit. But you're looking for things like a Brugada syndrome or a WPW, and that's what we're looking for here. That's the delta wave on a WPW. So,
or like a prolonged QT is another one where you've actually got a syncopal episode that can cause, and in reality, you've got to realize that a syncopal episode can cause seizure-like activity. And so that's another thing just from a practical standpoint. What happened on the onset of seizure? Was there an immediate return to consciousness? These are kind of clues that you can look for to let you know, is this a syncopal episode or seizure?
Yeah, fantastic. So it could read, seizure-like activity, EKG is showing this, likely diagnosis or something.
Yep.
And if it's a prolonged QT, Brugada, something, then that's how you make that question work together. The next step is laboratory analysis, and really what you're looking for is sodium. Again, we've already done the point-of-care glucose, ruling that out, and then you're getting that BMP, really looking for sodium. Less than 120 would be like your number on what it would be. And then again, first-time seizure in an adult, looking for or getting a CT of the brain, looking for some sort of mass effect. If it's trauma, we're obviously getting a CT scan looking for, any sort of intracerebral hemorrhaging that could go on. And that's about all there.
And when we talk about question stems, typically what you're going to see here is going to be things like, what's the next step in management? So if they're going to give you, a sodium of 116, you've got to start thinking, what's that next step in management? How are you going to correct this? So clearly, if they give you a fingerstick blood sugar of 20, you're going to give them, D50.
Absolutely.
If they give you a sodium of 112, then you're going to give them hypertonic saline. So when you hear these things, start trying to make that jump to the next step. What's going to be the next step in management if they give you that bit of information?
Perfect.
If they ask you what the first test is, it's almost uniformly going to be looking for a fingerstick blood sugar. So
awesome. And we'll go over that as this progresses on.
Yeah, we'll get back to it later.
So you know what to choose. Definitions. I've seen this multiple times coming up in different Q banks. So status epilepticus, if it's a seizure more than 5 minutes, repetitive seizures without coming back to baseline, they're trying to get you to status epilepticus and going down that pathway of benzodiazepines and second-line agents, which we'll cover there as well. Commonly, that comes up as well, something called Todd paralysis. This is also considered like a stroke mimic. So you have some sort of transient focal paralysis that happens after a seizure. And it can last for a while, so up to a couple hours, up to even days. And so, 20-year-old male seizure comes in now, now has, unilateral weakness or something to that effect. And, man, really doesn't sound like a stroke. And with the history of seizure, think Todd paralysis. And usually how I've seen those questions is, has a seizure, now has some sort of focal neurologic finding. What is the likely diagnosis? Maybe a Todd paralysis would be in there. Febrile seizure is another real common one that comes up, especially in the pediatric portion of it. And so if there is a child, anywhere between 6 months and 5 years of age, coming in with seizure-like activity, and they give you the vital signs, and there's a fever on there, 38, 39 Celsius, that's a febrile seizure. And typically what you're looking for is, do they return to baseline? There's no focal neurologic deficits on exam. Have they had a history of previous, afebrile seizures? goes down that pathway of, hey, this is a febrile seizure, not much more to do there as long as the child looks well. And there's other things that, go down that pathway. There's a simple versus a complex febrile seizure. If it's complex, there's a little more to do, but the vast majority of what I've seen has always been young child, seizure with a fever, now back to baseline. What kind of workup should you do? And then it's usually like reassurance. Doesn't need a CT scan, doesn't need lab
So
findings,
that's what I've
right?
consistently seen.
Perfect, okay.
And reassurance is the word they typically use. So
Nice.
the key on these is they're going to give you a febrile seizure. It's going to be an otherwise well-appearing child. They're going to make a point of a normal neurological examination, and they're probably going to make a point that it's a generalized tonic-clonic. So it doesn't apply to a focal seizure, but a generalized tonic-clonic, it's brief, full return to baseline, well appearing in the clinic. What's the next step in management? And it's reassurance.
Perfect.
So that's the key is they're going to try to get you to do more. They're going to try to ask about CT scan, lumbar puncture, all these other things, and they're trying to throw you off there. So the other key on this is it's got to be a fully vaccinated child. They can kind of throw you off with things like unvaccinated kid for a kid from another country. You get a kid from a third world country can be a different ball game. So, but that's all clues they ought to give you in the question stem.
Absolutely. All right, seizure is very broad in this part of the lecture there, and so we're going to kind of break it down into different things: drug-induced, withdrawals, infection. Kind of hit the big topics that most of these questions will cover. That also have antidotes that are associated with each one of these findings. Questions then. This one always comes up, isoniazid. I've never seen it clinically before, but I've seen it loads of times on question stems. Usually, it follows some sort of, it's a child who gets into, grandmother's medications, who's visiting from outside of the country. They're being treated for some sort of lung infection. And, you work this patient up as they have seizures and it's not responding to first, second line medications. You see a metabolic acidosis with an elevated anion gap. Isoniazid always is linked up with vitamin B6 or pyridoxine. Mm-hmm. Next one here is antihistamines. Again, will probably be covered in the toxicology portion of the review series, but we'll hit it here as well. So any sort of antihistamine or anticholinergic toxidrome, seizure is included in there as well. And I've definitely seen this clinically too. So someone who overdoses on Benadryl, and they go down that toxidrome of, mad as a hatter, hot as a hair, dry as a bone, red as a beet, whatever you want to choose to remember that toxidrome.
Tacky as a leisure suit.
There you go, yeah. Then it's benzodiazepines as your treatment choice.
And remember, that's the thing. So if you've got just a simple, uncomplicated, generalized tonic-clonic seizure, you're going to be tachycardic just from that sympathetic rush, but otherwise you're returned to normal. You're going to have a normal neurological examination. This is kind of like we were talking about earlier with hypoglycemia, hyponatremia. You're going to have these persistent, a persistent change in altered mental status, or in this case, you're going to have persistent changes in the patient's clinical appearance. So the question sim is going to describe someone who is not normal. They haven't returned to normal. Yeah. And it should mention these things. When you start noticing this laundry list of symptoms or signs, you need to start thinking about toxidromes. And it should give you all these in the question stem. You're not going to have to hunt for them. So
absolutely,
this is going to be your kind of febrile seizure differential, but they're also going to, like I said, they're going to notice dry mucous membranes. You're going to notice that they're flushed. Yeah. So you should get lots of clues on this one, and that needs to clue you in to think about something like a drug-induced seizure or toxidrome.
Yeah. Yeah. They typically don't try to hide it as well either.
No.
It's usually,
this is just do you know the toxidrome or not?
Yeah. Young patient found with a bottle of pills next to them, or this was a possible suicide attempt.
Yep.
So they'll definitely hone you in on those.
Yeah,
this is an overdose, and then your job is to recognize what it is, and they could ask in very different ways. What kind of toxidrome is this? Is this anticholinergic? Is this a sympathomimetic? And then the easy part there is that it's always benzodiazepines as the treatment. They could change it around and say, what's the toxidrome that's causing this seizure?
Yeah.
And then they can get you that way as well. Moving on, TCA toxicities, one of my favorite ones to go through. We'll keep it brief here. Anybody that has imipramine, amitriptyline, choose a couple of these TCA medicines, memorize them, know what a TCA is. It's not going to say TCA overdose in the question stem, but you'll get, whatever it is, 30-year-old male, presents with, seizure, home medications include, and one of them would be, amitriptyline. On initial evaluation, the EKG shows a widened QRS complex. Anytime you have that with seizure, we should be thinking TCA toxicity. TCAs have multiple different mechanisms of action, but here what we're talking about is that sodium channel blockade. So if you see a wide QRS complex seizure, you're doing the sodium bicarb, and these are pushes. And so this is the the differentiating factor between this one and an aspirin toxicity. And they might become more specific. I've seen it a couple times, but, we assume a TCA toxicity. How are you going to do a, bicarb drip? Is this going to be a bicarb push? And this one will be the IV boluses of sodium bicarb to narrow that QRS complex down.
And I think if you got a question, probably it would mention this is a patient that comes in after having a seizure.
Yeah.
They present with the following EKG. And I think that's probably the only way you're really going to get away with a good test question at this level about that.
Absolutely. And then on the other side of that here's the salicylate toxicity. Wintergreen oil classically comes up, especially with a pediatric seizure. Someone's making, things at home, they get into wintergreen oil and this occurs, or a possible suicide attempt. Classically here, respiratory alkalosis, a metabolic acidosis with an elevated anion gap, and then to contrast this with the TCA toxicity, this is the sodium bicarb drip that you're doing to alkalize the urine to then pull that the aspirin out so you can urinate it out. And then if not, hemodialysis are the big things there. 4 real common ones, seen questions on those multiple times. Mm-hmm. 2 big withdrawal type seizures here. Starting on the top one here. So alcohol withdrawal. Again, this will be patient coming in who's altered, tachycardic, who is irritable, hypertensive. They're tachycardic. Last alcohol beverage was somewhere in the range of around the 48-hour mark time period. And then they begin to have a seizure. How is this going to be treated? Benzodiazepines, commonly the answer choice here. If for some reason they don't choose benzodiazepines, then they'll add on like a phenobarbital or something to that effect.
Now, and I think the key here to remember is, so this does not equate to delirium tremens. Alcohol withdrawal seizures are a unique thing. They start earlier, so they can start within 6 hours of discontinuing drinking. So basically, hypothetically, you could stop drinking, fall asleep, and then have a seizure in the morning. This can happen much, much sooner. 48 hours is when you start seeing kind of the peak of delirium tremens. So a lot of times that's the point at which you'll have questions on that. So I think that's an important thing to differentiate as far as test questions, is that if they're going to write about an isolated alcohol withdrawal seizure, probably you're going to get it within the first day. If they're trying to cue you in onto delirium tremens, they're going to tell you 2+ days out. Mm-hmm. Because that's kind of the first stepping point into where you're going with this. With alcohol withdrawal seizures by themselves, you're probably really just going to have a benzodiazepine. If you get into delirium tremens, you may have to go into second and third line. So that changes how you have to think about these questions. Yeah.
Have you seen much of like the hallucinations that then get added into like a delirium tremens question versus just an isolated?
That's when you get into altered mental status rather than just seizures.
Fantastic. Yeah.
So, or you're going to have status epilepticus, that kind of thing. You'll have the failure to come back to normal within in between seizures. Awesome. Which is more your altered mental status. And then they'll give you other clues about autonomic instability. So I think that's an important point here. And then we can move on. I think the other thing about these, and we've got alcohol, and then the next one here is benzos. You can also put barbiturates here. So you always think about the big 3 that attach to GABA, alcohol, barbs, and benzos. So any of these withdrawals can cause seizures and then can ultimately lead to death, is what I'll normally think. These are your big 3 dangerous ones.
Absolutely. Yeah.
Which are ironically treated with benzos.
With benzos, yeah.
So
and the big, I think like the distractor here, especially on a benzodiazepine withdrawal, they'll put in flumazenil. And we always recognize flumazenil is the antidote for benzodiazepines, but more so for iatrogenic,
pediatric.
Usually it's a pediatric. Mm-hmm. I gave too much benzodiazepines, they start to seize, and now I'm giving flumazenil to reverse what I did.
If
this is someone who presents,
or they got into mom's or dad's,
absolutely,
Xanax stash.
Yeah.
So first time they ever took it, they're not used to taking it. Then you can use it to get them off.
Yes.
And this is really just to avoid respiratory decompensation.
Correct. Yeah.
We don't normally think of that with benzos in particular, because that's why we use benzos, right? Is so that we don't have to worry about respiratory depression. But in large enough doses, and particularly in pediatrics, it absolutely can happen.
Absolutely.
So
yeah. So think flumazenil as, oops, either I did it or it was an accidental overdose. In a child. That would be then the flumazenil. Other than that, think just benzodiazepines. Moving along into provoked seizures being infection. So meningitis, we'll hit this one number first. So, I mean, this is the classic neck stiffness, headache, fever. It's like the triad of meningitis, which on a question sim, they'll push you that direction. Most common cause would be strep pneumonia. If it's an HIV patient that they bring in, most common cause will be Cryptococcus neoformans. And then here, you have to go into your age-determined antibiotics. The seizures would obviously be with benzodiazepine treatment, but then your antibiotics will be your definitive measure in treating the underlying source. Next one here would be encephalitis. So seizure plus some sort of focal neurologic deficit. You think of like HSV encephalitis. You think of varicella zoster encephalitis if they're immunocompromised. Again, acyclovir, we're treating the underlying cause, and benzodiazepine for your treatment of your seizure.
And classically, they're going to give you, really, if they're going to be fair on this one, they're going to give you like a temporal lobe seizure. So this is one they'll give you like that focal onset with secondary generalization. Because that's classically the herpes viruses affect, particularly herpes simplex, will affect the temporal lobes.
Absolutely.
So you'll get these kind of weirdly described seizures. But anything with altered mental status and kind of those meningitic signs, you need to be thinking about encephalitis.
Yeah. The other common one that always comes up with herpes simplex encephalitis. So when you get the lumbar puncture, the red blood cells don't clear. Right?
Yeah.
Classically like a hemorrhagic type deal.
Yep.
I've seen that on question stems where, tubes 1, 2, 3, and 4, remain, red blood cells all throughout. And that also should clue you in. This is an HSV encephalitis. And if they're immunocompromised, then think varicella. Last one on infection, brain abscess. So again, seizure plus focal neurologic deficit. Most common causes of these would be some sort of strep or staphylococcal species that's migrated up from, somewhere like in the ENT space there. Common questions that I've seen on this one has been, treatment of choice. Usually they add on like a Rocephin. Then you have to add on that anaerobic coverage with that metronidazole to cover for those, like the oral flora and things that can migrate up. Again, benzodiazepines, focal seizures, that sort of deal. But a lot of it has been like antibiotic choice is what I've been seeing on the brain abscess questions.
So the other thing, too, is that new onset seizures, when we talk about the reason that you image new onset seizures, this is the reason. And particularly any new focal onset seizure is a brain abscess or a space-occupying lesion until proven otherwise. So that's kind of the other big thing with all these when we talk about the reason of your first test in these folks that have got a fever and a new onset seizure.
Yeah.
It's a CT, and this is why. This is what we're looking for.
Absolutely.
To make sure there's not a space-occupying lesion in there.
Perfect. A lot of questions have come up that I've seen before is, like what Dr. Harrington always says, these are going to they're going to push you down this pathway of, hey, this is an infectious source of a seizure. So whether it be, fever, headache, focal neurologic deficit, I've seen some questions where, they'll say, what's the next best step in management of this patient? And it'll be, a CT scan, lumbar puncture, antibiotics, admission, whatever it is. And if it's a high suspicion, then you want to begin treatment immediately. Loads of questions like that where if it's high enough suspicion, broad spectrum antibiotics to cover that based off of their age will be the right answer. And they'll try to clue you in and say, well, I think I have to get the CT scan before they do the lumbar punctures. Maybe I should do the CT scan first. Not the case on here. Broad spectrum antibiotics first, and then move forward with your imaging, your lumbar puncture to find.
And I think
source.
The big thing when you think about these, so you think about what information you're going to be given. So you're going to be given an altered patient with a seizure who's tachycardic and febrile. So kind of that, when you get that, you need to decide, does this sound like an overdose and this is a toxidrome, or is this an infectious process? Again, we're talking about test questions. So in order to answer this correctly, they've got to give you something to push you one direction or another.
Absolutely.
So that's when you're looking for what other clue do they have that's going to help me out here. So if they're immunocompromised or if they're found next to pill bottles, that's when you're looking for that next step in management. If they're unstable, the first step, if they're seizing, the first step is treat the seizure because you have to stop that. Past that, if there's nothing clear, then you have to start the empiric antibiotics. So, again, it shouldn't be, these aren't curveballs. These, typically, they're going to be some clues, but that's kind of how you need to be thinking about it and how you need to be differentiating these things as you're reading the question. Clues that you're looking for.
Perfect. Okay, moving into electrolyte disturbances. So again, we'll put it out there. 20-year-old female comes in, seizure has now since resolved, remains altered on examination, electrolytes return back, and you have a, hyponatremia. Typically, this is seen with a sodium less than 120. Again, you'll be like a sodium of like 110, 106, something to that effect. and you treat it just as how it's happened. So hypertonic saline will be the treatment of choice for anyone who's seizing because of hyponatremia. The other one that I've seen come up is a pediatric patient who is seizing. You give, your benzodiazepine. It's not breaking the seizure. They continue to seize. You try a second-line agent, be it Keppra, phosphonatone, whatever it is. They continue to seize. A further discussion with mother says that, they've been diluting the formula, because of, whatever the reason may be. Mm-hmm. But you get this history from mom in the question stem that the formula has been diluted. That includes, on hyponatremia. I now need to do hypertonic saline to then stop the seizure. Mm-hmm. Same one again here is hypoglycemia. Loads of questions on here, especially when it comes down to the pediatric population. Think of like inborn errors of metabolism. If this is an adult with an insulin-dependent diabetes who's maybe taken too much on accident. And then it depends on what type of glucose you're going to give. And this down here, multiple questions kind of come up either through, Roche or different Q banks. So if it's a child less than 2 months of age, we're giving D10 at 5 mLs per kilogram. And the easy way to remember these things is everything's going to add up to 50. So if it's less than 2 months, it's D10 at 5 mLs per kilogram. 10 times 5 goes to 50. If it's between the range of 2 months to 8 years, a pediatric who's seizing because of hypoglycemia, D25 at 2 mLs per kilogram. And then adults or anybody who's greater than the age of 8, you're doing D50 at 1 ml per kilogram for your treatment of choice here. Typically isn't just, provide glucose as the answer there. A couple other presentations that can come along when we're considering someone who has seizure is pregnancy. So eclampsia. So when we started off the presentation, the first initial test to order, if this is a female childbearing age, always get a urine pregnancy test. And that'll definitely be in the question stem. Someone who is seizing doesn't respond to first, second line agents. Boyfriend comes in or family comes in, reports that the patient is pregnant. What's the next best step in management of the patient? Anytime we always think eclampsia in emergency department setting, reflex is magnesium sulfate. And that's what we're looking for here. Just to kind of complete eclampsia here is the diagnosis itself. We're looking for a pregnancy that's beyond 20 weeks. They're hypertensive, more than 140 or more than 90 millimeters of mercury, plus protein, plus edema, usually complain of like headache, vision changes, abdominal pain. And then the other big key factor here is, let's say they're 6 weeks postpartum. That one also comes in loads of times, especially on test questions. Yeah. A 30-year-old female comes in actively seizing, not responding to Ativan. Mm-hmm. Husband arrives on scene, says they recently just had a baby. What's the next best step in management? Mm-hmm. Magnesium sulfate every time. The other one I want to throw in here as another one to consider is hyperglycemic hyperosmolar state. So again, this is a glucose on the other side of the spectrum. So we covered hypoglycemia. Now we're covering the hyperglycemia. And this one usually gets attached to diabetic ketoacidosis. But the big differentiating factor here are neurologic symptoms. And that can include a seizure, which I've seen before on test questions and clinically for that matter. And so again, you'll work this patient up. They'll give you a glucose somewhere in the thousands. Their serum osms are elevated. There's no acidosis. There's no ketones. And the patient is seizing. They're altered. And the treatment here is aggressive volume repletion, correcting that dehydration, and then that insulin drip as well. Mm-hmm. All righty. So to recap, first line in management, so airway, breathing, circulation, then don't ever forget the glucose, especially on these seizing patients that come in. First test to order, it's going to be a point of care glucose every time. Patient who's actively seizing, think of benzodiazepine as your first line agent. And then if they ask for a second line agent, Keppra, levetiracetam, phosphonatone, or valproic acid would be your second line. Haven't seen many that have taken a question stem all the way down to the third line agent. Usually at that point, you're looking for intubation and sedation with propofol, Versed, phenobarbital infusions. But usually most of these questions that we'll be getting will either take you down the status epilepticus route, and the answer choice will be a benzodiazepine or a second line agent. And then if they want to take it a step further, that's where all these toxidromes and where these other things come into play on these question stems. And so...
And that would be my approach. Is I think, generally speaking, they're going to ask you probably what's the first test, and so you need to be comfortable with what's the first or the next step.
Yeah.
So be comfortable with always checking a glucose early. If somebody's got a fever, kind of reflex to they need antibiotics first.
Perfect.
Unless you can identify a toxidrome, and then it's going to be benzodiazepine. So look for your lorazepam. If it's not one of those, they're probably pushing you into trying to identify something unusual. So I think be real familiar with your first steps, and then if it's not that, be familiar with what we're getting ready to talk about here. Start thinking about the weird things. Start looking for zebras, because that's probably why they're not resolving.
Perfect. Let's practice. 30-year-old male comes in.
Well, here we've got reversible causes.
Oh, I'm ready.
Yeah. So these are the things I think you got to think about here.
Absolutely. So if it's a TCA overdose, big things that clue you in, someone who is altered, febrile, widened QRS on EKG.
And they'll almost certainly give you an EKG with a widened QRS.
Yep.
Anticholinergic we talked about earlier, you're going to have a laundry list of symptoms and probably a pill bottle. So you're going to be tachycardic, you're going to be hot, flushed, dry.
Yep. Same thing with salicylate.
Yep.
Think wintergreen.
Yep.
Think wintergreen oil. Isoniazid. Think someone who's visiting from outside the country.
Yep. Taking some unnamed medication for pulmonary disease.
Absolutely.
Is how they usually word it.
Yep.
So.
Yep. With your withdrawal patterns, look for the history. Alcohol, benzodiazepine withdrawals. Think about benzodiazepines as the treatment. Again, if they're febrile, headache, neck stiffness, immunocompromised, think infections. And then your electrolytes. Again, fever, altered mental status. And then cluing in diluted formula, hyponatremia, low glucose. And that about hits the highest yield ones that I can think of for seizures.
Yeah, I agree.
All right. Couple practice questions. 25-year-old male presents to the emergency department with seizure. Family witnesses report patient shaking for around 30 seconds, then being confused for about 20 minutes following. In the ED, patient is back to baseline with a mild headache, unremarkable vital signs. Neuroexam is normal. What is the best next step in management of this patient? So again, going back to the initial one there, this is an adult, first-time seizure, laboratory analysis, tox train, CT brain, full workup here. Question number 2. So 25-year-old male presents to the ED with altered mental status, febrile at 39 Celsius. Girlfriend reports he has been complaining of a headache, neck pain last 2 days, begins to seize during your examination, which goes away with lorazepam. What is the next best step in management? Again, here's the fever, the headache, the neck pain, really cluing in on some sort of infectious process, looking for empiric antibiotics first, not that CT or that lumbar puncture. Last one, 25-year-old female presents to the ED with seizures. The patient was given lorazepam en route by EMS. She is post-ictal and begins to have another seizure. IV lorazepam is given again. She started on IV phosphenotoin. Despite this, continues to seize. What piece of information is critical to finding the right treatment? Looking for a history of epilepsy, history of giving birth 2 weeks ago, history of TBI, history of a brain tumor. Looking here, history of giving birth 2 weeks ago and needing magnesium sulfate to abate those seizures.
And so this is what we talked about. If they're throwing you these things, like you might want to say something like a history of epilepsy. But remember, if they're giving you multiple failures of appropriate treatment, they're doing it for a reason. So the question really is asking you what unusual seizure. You could also do this with patient was recently started on treatment for a pulmonary disease. You're looking for why would this patient not respond to conventional treatment. So this is a good example of that.
All right, guys, that's all we got for you. Thanks.